discussing a patient that I took care of. This is the case of Mr. RW. He's an 83-year-old Caucasian male with a significant past medical history of diabetes, CHF, hyperlipidemia, dementia, BPH, AICD, two MIs. The most recent one occurred September of 2018. This gentleman came in with the chief complaint of slurred speech and left-sided weakness. The onset was at 8:10 in the morning. The patient's daughter reports that she went to visit her father this morning and noticed he was having difficulty ambulating and speaking. She reports that the last time she saw him was 9 p.m., so the patient's last well known is 9 p.m. The patient has no pertinent family history. He does have a positive social history for smoking 2 to 3 cigarettes per day. He's been smoking since he was 18 years old. He does report drinking 2 glasses of whiskey every night, denies any illicit drug use. On review of systems, everything was unremarkable except for his musculoskeletal, which was positive for left upper and lower extremity numbness and weakness. On his physical exam, the patient appeared anxious. He had no trauma to his head. His eyes, he did show a positive left eye droop. He had left upper extremity weakness. He was showing a 3 out of 5 strength and complete paralysis to the left lower extremity. Neurological, he had the left facial droop, right gaze. He was alert and oriented times 3. And he had an NIH total score of 17. I am going to grab my NIH to go through it with you. So on open eyes and close with grip release hand, he had a 2. On current month and age, he did get a 1. Best gaze, he got a 2. Facial paresis, he got a 2 for partial paralysis. Motor function to the left leg was a 2. He had sensory mild, and it was a 1. Best language, he received a 1. Dysarthria, he had a 2. He was having a lot of expressive aphasia with dysarthria. Extinction and inattention, he had a 1, so a total score of 30. Upon assessment, this for me, 83-year-old Caucasian male, significant past medical history of diabetes, CHF, hyperlipidemia, dementia, BPH, AICD, as I stated above. My assessment, my problem list would be an acute ischemic stroke, confirmed via CT, CTA of the neck and head with and without contrast, showed a proximal M2 level occlusion that was noted on the right, which confirms the left-sided paralysis and weakness. On consults to teleneurologist and interventional neurology, both stated that the patient was not a candidate for either TPA or intervention due to the patient having a greater time span of more than 12 hours. So my plan was to admit this patient directly to the neuro intensive care unit, neurological checks Q15 for the first hour, 30 for the second hour, and then every hour for 24 hours, vital signs Q15 while the patient remains in the intensive care unit. Maintain a systolic blood pressure between 145 to 165 to allow for cerebral perfusion. Repeat CT scan will be ordered in the morning due to the patient having an AICD that disqualifies him for an MRI. The patient will have speech, physical, and occupational therapy. He will be kept NPO until he is able to have a dysphagia screen and a swallow study to prevent this aspiration. My other problems that I will be addressing will be his diabetes. We will just continue on his anti-glycemics, check VGLs before every meal, and then check a full lipid panel to see if that has any association to his current stroke. Hyperlipidemia, we will order a lipid panel, which is confirmed with the diabetes. We will check the hemoglobin A1C and continue him with his current medication, which is lovastatin. For CHF, we will bring on cardiology. We will do a stat echo to assure that cardiac function hasn't changed since the last time he had it, which was 5 years ago. It was at 25%, and that's why he had an AICD implanted. We will continue with the patient's antihypertensive medications, as well as assure that we are meeting the stroke criteria, which is a beta blocker, an ACE inhibitor, and a statin, which the patient is currently on metoprolol, lisinopril, and lovastatin. We will be cautious when we are planning to resuscitate the patient with fluid due to his CHF. For his BPH, we will have strict INOs. We will make sure that there is no urinary retention, and we will continue his tamsulosin. For his dementia, we will just assure to reorient the patient at all times, have clear and simple communication, and involve family at all times with care plan and discharge planning, as well as continue the patient on donepezil medication for the dementia.